So there are a few trials which have been done, large-scale clinical trials, which have harnessed the inflammation concept. The first, which was led by my colleague Dr. Paul Ridker, and I was privileged to work with him on this trial, was Jupiter. Jupiter used the inflammatory biomarker, hsCRP, to allocate therapy, statin therapy in this case, to individuals who met no guideline criterion for having statin therapy. And that showed in primary prevention a striking benefit of allocating statins based on inflammatory status, but it did nothing in Jupiter to test the inflammation hypothesis itself. And so Dr. Ridker and I together set up a study called the canakinumab Anti-Inflammatory Thrombosis Outcomes Trial, or CANTOS for short. And this trial selected individuals now in secondary prevention who'd already sustained an acute coronary syndrome and were in the stable phase of ischemic heart disease, but who, despite being on a full panel of standard of care, including very effective statin therapy, had an hsCRP above median for the population, greater than 2 milligrams per liter. And we randomized those individuals to various doses of a monoclonal antibody called canakinumab that neutralizes a particular pro-inflammatory mediator, a cytokine known as interleukin-1 beta, that actually I've been studying in my basic research laboratory for decades, and I hypothesized played a role in atherosclerosis way back in the mid-1980s, if you can believe it. So it took us 30 years to go from the test tube to a clinical trial. And this clinical trial, which enrolled over 10,000 people, showed that its primary endpoint was reduced by about 15% by adding an anti-inflammatory therapy in individuals with residual inflammation, despite the whole menu of our standard of care in secondary prevention. So this trial indubitably proved the inflammation hypothesis of atherosclerosis. Now, in those individuals in the trial who achieved a good result with the antibody, as gauged by a drop in the CRP to lower than median, it was striking that they had not only a greater benefit in terms of the primary endpoint, but also they had an over 30% reduction in cardiovascular death and in all-cause mortality. So this is really a striking result, I think, that put inflammation on the clinical list of things that we must think about as doctors taking care of patients post-myocardial infarction.